I really want to thank the organizers. I want to thank the Washington University ADRC for this invitation, and I especially want to thank Mr. Norman Seay and the advisory board for this award. I was not expecting an award at all. I thought I was just coming to share information about what we're doing in Chicago, so it's a real pleasure. Today I'm going to talk a little bit about some of the work that we're doing in Chicago in our different cohorts with a particular focus on African Americans. So please feel free to stop me as we go along if you have questions. Wait, okay. So this slide is just to show you that, we think that, Alzheimer's disease is terrible. It is a terrible disease. But even Superman in his later years had problems with memory. He's standing in the window and saying, dang, now, where was I going? This is something that we're all going to have to face as we get older. Luckily, not everyone in this room is going to get Alzheimer's disease, but many of you have probably been touched with a family member or a friend or someone who's had this devastating disease. So what we're trying to do is to figure out, is there anything that we can do to alleviate this problem for the future generations? There's an important trend in studying Alzheimer's disease. If you look at the aging population, you'll see that over time there are more and more people living to advanced ages. So like in the early 1900s, you didn't have very many people over the age of 65 because they died through childhood diseases. And as we got better vaccinations and better public health measures, you see this increase. So here's 2040, you see there'll be many, many more people living to 85. The yellow bar is 85 to 75 to 84. And in minorities in particular, we're going to see an increased diversity for minority populations in the oldest segment of the population. So in 2000, older whites over the age of 65 made up about 83%. But in 2050, the numbers are going to decrease. They're going to be just 64%. In contrast, these other bars here are the minority populations, and their numbers are getting much bigger. They're growing much more rapidly than the non-Hispanic white population. So what does that mean for us? Because we have this increase in life expectancy, we have better control of infectious diseases of childhood, like things people used to get, and you would just put a sign on the door and say, you're quarantined, stay out. And, now we have these improvements in health. And so we see a decline in death due to certain illnesses, and we see changes in lifestyle factors. But, this slide is just to show you, sorry I can't get this thing to work right, it's just to show you that the things like stroke and coronary heart disease, these are the things that used to really kill people, but you can see these curves are sort of going down over time. So, we have better health prevention measures, we have better medications, so we're not seeing as many deaths from those kinds of diseases. But as we get more and more people in the older aging categories, we're going to see an increase in diseases of aging, particularly chronic diseases, neurologic conditions, especially cognitive decline. These are among the most common problems in older persons. This shows you the distribution of Alzheimer's disease cases in the United States, and you can see the black are the states that have greater, God, I'm so sorry, maybe I shouldn't use a pointer. The black are the parts that have more than 200,000 cases. So you can see Missouri's not that bad off, but the projections are going to get even worse as time goes on. Thank you. I'm challenged when it comes to this kind of thing. So the whole idea of memory loss is not new. There's been more and more focus on it lately, I think, but we've known about people losing their memory since ancient Egyptian times. This is a sort of a quote from Hotep. The progress of age changes into senility. Decay falls upon man, and decline takes the place of youth. sight fails, the ear becomes deaf, his strength dissolves, speech fails him, the mind decays, remembering not the day before. So, you know, in 2200 BCE, people were noticing that you have these memory problems. You have this change as you get older. It's not something new. Alzheimer's disease was actually coined by a German doctor, Dr. Alois Alzheimer, in 1906. He had a patient named August D., who she was in her 50s, who he had been seeing for about 5 years. And this is from his case report. He said, from time to time, she was completely delirious, seeming to have auditory hallucinations. When the doctor showed her some objects, she first gave the right name, but immediately forgot everything. In a writing test, she repeated syllables, omitted others. In her conversation, she used confused phrases. She did not remember the use of particular objects. And this is something very common that we see now in our Alzheimer's cases, and we now know that this wasn't some strange neurological condition that she had. We know that she had a dementia, and the way we define dementia now is significant loss of cognitive function in an adult. You know, people always kind of get mixed up, is it, you know, dementia or Alzheimer's disease, and you really got to think of dementia as the umbrella term. You can get dementia for many different reasons. But it lasts at least 6 months in duration, and you have to have at least 2 spheres of mental activity compromised. Now, Alzheimer's disease is the most common cause of dementia. You can get dementia from a stroke, you know, you can get dementia from depression, but Alzheimer's disease is the most common. And that is a progressive decline of memory and other cognitive abilities relative to a previous level of performance. And the way we document it is by memory testing, and is not entirely due to another condition. The most important cognitive ability that is compromised in Alzheimer's disease is memory. And memory is just the recording, retention, and retrieval of information. And it accounts for all knowledge gained through experience. So, you know, anything that you know, specific events, knowledge of facts, acquisition of skills, that's all your memory. And when you get Alzheimer's disease, that is what is affected, your actual memory. There are different kinds of memories that we study, but episodic memory is probably the hallmark of Alzheimer's disease. And this is memory for personal episodes that happen to you. But, you know, but there are other kinds of abilities that are eventually compromised over time. This shows you a picture of a brain. This is a normal brain of someone, you know, who did not have Alzheimer's, and this is a person who had Alzheimer's. So you can see the brain looks, you know, a little different. It's a little bit more shrunken. There are more spaces here than the normal brain. And if you look under the microscope, I mean, if you take a slice of the brain, you can see that here's a normal brain. You know, it looks much more meaty, and here you have these big holes in the brain with Alzheimer's. And this is just to tell you that, you know, it's not just a mental condition, it's an actual brain disease. There's something physically happening to your brain. We know now that there are these characteristic plaques and tangles that occur in your brain when you have Alzheimer's. This is just a schematic showing you what it looks like under the microscope. I'm going to kind of quickly go through this. There are some treatments for Alzheimer's disease. They're not that great, unfortunately. They help maybe about half the people, and they may last, you know, they may slow your progression about 6 months to a year. But we have basically 2 different classes that work on different neural systems in your brain, and, you know, people will often get, you know, you probably have heard a lot about Aricept and Namenda. They often get those together. So when we think about Alzheimer's disease, what we really want to know, you know, are there survivors? You can think about not every single, but many diseases that we once thought was a death sentence. Now, you know, breast cancer. We used to think once you got breast cancer, that was it for you. But people actually talk about, you know, surviving breast cancer, their breast cancer walks. You know, there are maybe people in the room who have survived breast cancer. There are people who have had heart attacks, you know, and they can say, I had my second, I had my third heart attack. Even stroke, they're stroke survivors. Mr. Seay is a good example. You know, he had a stroke and he's still able to function and be very involved in the advisory board and do his other leadership roles. But what about Alzheimer's disease? Where are the survivors? Has anyone ever heard of someone surviving Alzheimer's disease? These are just some important, people in the Black community who had Alzheimer's disease, and they're no longer with us. They did not survive. And the Alzheimer's Association estimates that 10 million U.S. baby boomers will develop Alzheimer's disease. That is a lot of people, 10 million people, over the next 20 to 30 years. And Alzheimer's disease is the most, here's the prevalence, and it's very costly. It's the third most costly disease right now, costing $100 billion in both formal and informal care costs. And a new study shows that Alzheimer's cost in Medicare is going to jump by 54% by 2010. That's right now. This increase threatens the survival of the current U.S. healthcare system unless a way is found to prevent or delay the disease. And that's what we focus on at the Rush Alzheimer's Disease Center. Are there ways that we can actually prevent this devastating disease? If you look in the news, you'll see things like poorly controlled diabetes increases the risk of Alzheimer's. This is from the news and the literature, actually. High blood pressure and high cholesterol increase the risk of Alzheimer's. Higher levels of physical activity may lower the risk of Alzheimer's. If you look at these different factors, these are factors that are prevalent in African American communities. We have a high rate of diabetes, we have high rates of high blood pressure, high cholesterol, and we tend to be fairly sedentary. We don't, do exercise as much. And so these are factors that are linked to Alzheimer's. What does that mean for minority communities that have high prevalence of these conditions? In fact, the Alzheimer's Association a few years ago issued a special report on African Americans called the Silent Epidemic, where they tried to increase awareness about this disease in African Americans because it was being suggested that the disparity might be great in African Americans, that some reports suggest that maybe they are at 2 to 3 times, they have 2 to 3 times the risk of developing Alzheimer's disease. And so a huge media blitz was started where, there were, this is a VHS actually, and, pamphlets were put out to try to educate minority communities and let people know that no, Alzheimer's is not normal, it's not a normal part of aging. There's actually, this is actually a disease that you can do something about if you don't wait too late to the last minute. Here I'm showing you again, the growth of the African American population from 2003 to 2050. This increase here suggests that the burden of cognitive impairment may increase dramatically for African Americans. If older African Americans are growing at a disproportionate amount, and it already looks like they may have more cases of Alzheimer's, that means that the burden of cognitive impairment is going to increase. There's a study that was put out that suggests that blacks were more likely than whites to have cognitive impairment. So this just shows you the rates for whites, blacks, and Hispanics at different age groups. And blacks are the yellow, African Americans. And you can see at every age group, there's a higher percentage of African Americans that have cognitive impairment. And this is from 16,000 people, a study called the Health and Retirement Study from across the country. And so there's been numerous studies done now looking at these disparities. And, the data are somewhat mixed, but most studies do find that there seems to be a little bit more cognitive impairment in African Americans than other populations. Now, we don't really know why that is. Is it because there's more Alzheimer's, or is it because of some measurement issues? But this is what's coming down, in the different studies that have been done across the country. And in fact, the Alzheimer's Association estimates that older African Americans are about 2 times more likely than older whites to have Alzheimer's disease and other dementias. So what are we at the Rush Alzheimer's Disease Center trying to do about the problem of Alzheimer's disease in African Americans? And what we really want to know is, can Alzheimer's disease be prevented? I'm going to tell you just a little bit about 4 large cohort studies that we have at the Rush Alzheimer's Disease Center, and just show you a little bit of some of the findings that are coming out of what we're looking at. So one is called the Chicago Health and Aging Project. This is a map of Chicago, and this is where Rush is located, just west of downtown. And the CHAP, as it's called, is a study that's done on the south side of Chicago in 3 contiguous areas. It was a complete census of all households in these 3 areas was done, and all residents aged 65 and older were asked to participate. Of about 7,800 eligible, 6,100 enrolled into the study. And people come from a variety of different housing. This is one of the more upscale parts of the neighborhood. It's called Beverly. But we have, more modest houses in other areas. And these are all, we go to people's homes. These are home visits, and people are seen every 3 years. And we give them an interview, and we try to measure incidence of new cases of Alzheimer's disease. They all enroll whether they have Alzheimer's or not. We take everyone in the community over the age of 65. Now, the religious order study is another study that we have. It consists of 1,100 older nuns, priests, and brothers without known dementia from across the United States. They all agreed to annual cognitive and motor testing, and they all agreed to brain donation at the time of death. We have very good follow-up, and people have been in the study for up to 17 years, and we have very good autopsy rate, with about 500 brains to date. But this study, is very select, because these are nuns, priests, and brothers. They have a very, restricted lifestyle. They all live together communally. They eat the same things, and it's primarily white. There's probably about 9 to 10% minorities in this study. These red dots show you they come from all over the United States. Those are some of the participants. So because of the select nature of the study, we started another project called the Rush Marine Aging Project that was for just lay people. And this consists of 1,400 residents from about 40 retirement communities and senior housing enrolled from across the Chicago area. They also agreed to annual testing and brain donation, and there's good follow-up rates and very good autopsy rates. They come just from the Chicago area, pretty, spread out throughout Chicago, but they live in continuing care retirement communities. And, we tend to have fairly low rates of African Americans living in these kinds of communities. African Americans either tend to stay at home with their loved ones, or they may, end up in other kinds of housing, but definitely not things that look like this, at least not in Chicago, maybe in St. Louis. So to increase the diversity in MAP, and that study is called MAP, we also enroll from subsidized housing through HUD and try to get our numbers there. But still, this study only has about 8 or 9% African Americans. But through these studies, we've learned quite a lot. We've learned that there are genetic risk factors that increase your risk and some that decrease your risk. And this has been, lots of studies across the country have found similar findings. What we also have found is a host of environmental and experiential factors that seem to either increase or decrease your risk. And these are the things that I really care about, because some of these things are things that you can actually do something about. I mean, obviously not your gender or your age or your race, but there are other things on this list that you can change and maybe change how Alzheimer's is affecting you. Things that you can do over here to decrease your risk. The problem is with that list is that most of these studies have been conducted with white samples. And I told you, there's just very little known about what's happening with African Americans. And when you do have African Americans in the sample, it's usually fairly small samples, restricted range of socioeconomic status, and we don't look at potentially important cultural factors. Now, when I've been looking at some of these studies, I have found, I've published, that there are some factors that appear to operate the same in African Americans and whites. So we found that people who were more cognitively active, who read more books, went to the museum, did, cognitively stimulating activities, they have a decreased risk of Alzheimer's. And that's true whether you are black or white. And then similarly, there are things that seem to increase your risk, like having diabetes or smoking. That's true whether you're black or white. But then this is just showing you, someone who has a high level of social networks. We ask people, how many friends, relatives, and children do you see at least once a month? And people who reported that they see a lot of friends and relatives, this is how they decline over time. So we test them every year, and we measure how their memory changes over time. So people who have a lot of friends are staying pretty stable. People who have very few friends or relatives are kind of declining over time. And this is true whether you're black or white. But we, interestingly, have found that there are some factors that appear to operate differently. So we found that people who were more socially engaged had a decreased risk, but that was only true in whites. We also found that people who tended to use moderate levels of alcohol, which is like 3 drinks a day, had a decreased risk. But again, that was only true in whites. And then we found some things that seem to increase your risk, but again, these things only seem to operate in whites, not in blacks. I'm just showing you here a picture of the of the alcohol effect. So these are black, and these are not black. And if you just look at this line here, this is 6 drinks a day. So that's pretty bad for everybody. But 3 drinks a day is this line here. So if you're not black, this line is not as steep, it's not declining as fast as this line if you're black. So alcohol seems to be protective for whites, but not for blacks. I'll skip that one. So, but what could be causing the risk factors to operate differently in different groups? Are we missing something? So that's when I wanted to start looking at these factors in African Americans. Now we have a clinical core at our center, which consists of about 300 African Americans who don't have dementia. They're about 65 years or older. They all agree to annual in-home evaluations and a blood draw. We have good follow-up, and about 50% have expressed an interest in donating their brain after they die. But I started a study in 2004 called the Minority Aging Research Study. This is really my baby because I worked so hard for it. And it consists of over 400 African Americans who enroll when they don't have dementia, they're cognitively normal, and they're 65 years and older. The only thing you have to be at least 65, you have to be black, and you have to not have been diagnosed with dementia. They all agree to us coming to their home and giving them clinical evaluations, and there's about a 95% follow-up rate. And I was recently renewed for another 5 years to try to get organ donation in this population. And so the interesting thing is, we go to people. I go out to churches, senior buildings, wherever I can find black people and where they congregate. Here I found out about a tennis group. They've been getting together every year for the last 40 years, playing tennis at this park. And I found out about them, and I took them lunch, and I gave a presentation on Alzheimer's disease and the importance of participating. And I had about 3/4 of the people here signed up for the study, and they're still in it. They're very active, they're healthy, of course. But it's like I'll go wherever you are. I want to show my commitment. I want to get you into my study, so I'll come wherever you are. And people, they seem to, to really it resonates with them. My sample comes from, different parts of the city. Apartment buildings, single dwellings. And interestingly, because most of the research is focused on whites, I decided to look at cultural variables that may be important but are rarely studied. So I asked questions about experiences with discrimination, about the quality of education, neighborhood conditions, whether there's caregiving stress. A lot of my participants are grandmothers taking care of their grandchildren. Now you have a 75-year-old chasing after a 3-year-old. That could be good or it could be bad. But we want to see, what is that doing to your memory? Financial burden. I asked questions about how do you identify with African American culture? What kinds of things do you do to cope? Spirituality and social support. These are factors that are rarely considered in studies, but I think might be important when looking at minority populations. About almost half of my sample were born in Illinois, but there's a good portion that are born in southern states, and there is some evidence to suggest, that there may have been some differences, especially in education, quality of education, between people born in southern states and in northern states. And we've begun to look at some of that. You can look here. This is a classroom, from that time where it was a one-room classroom, and here's a white classroom. Everyone has a desk, everyone has a book. You know, it's a very different setting. And we give our interview, we ask people about their experiences growing up. You know, these people are 65 and older, so they've gone through Jim Crow, they've gone through segregated schooling. You know, we ask a bunch of questions to look at their experiences with quality of education. And we're starting to see some interesting things. So people who attended segregated schools, there were about 40% who said yes, and about 59% said no. And we know that there are spending costs that were associated with different states. So people, you know, states spent different amounts of money for black schools and white schools across the country. You know, these things seem to have an effect on our cognitive testing. Even the length of school was different, you know, from North Carolina, whites and blacks. And I have people in my study who tell me that they did not go to school when it rained because, you know, they had to work in the field. You know, so what is this doing, you know, to people as they age, these kinds of experiences? That's what we're interested in. And, you know, we know that people of this generation had a very unique experience with Jim Crow and dealing with, you know, segregated facilities. You know, we try to take all these things into account in our research. We just had a paper come out where we asked people about how their experiences are with discrimination, and you see people who reported, you know, no discrimination is about a third of the sample, and then people who reported like 1 event, 2 events, 3 or more than 4. And then we measured something in their blood, an abnormal protein, and we found that people who reported more experiences of discrimination tended to have higher amounts of this abnormal protein in their blood compared to those who were reporting lower levels of discrimination. So that, you know, just perceiving that you were treated unfairly is doing something, and you're able to measure it and pick it up in your blood or in your testing. Similarly, people who were born in the South, this is a performance on our cognitive function test. If they're born in the South, they're performing lower than those who are born in the North, probably saying something about the quality of education. So what will it take to prevent and treat Alzheimer's disease? It's going to take dedicated researchers and, you know, researchers who are willing to go to the people and find out what their needs are. I think the WashU ADRC is doing that with the advisory committee, you know, and getting your input and trying to figure out what is important in the community. It's going to take study volunteers. We can't do this if we're not participating. You know, we acknowledge that there were many past abuses done to the minority community in the past, but things have changed, and we do have dedicated researchers who are really interested in finding out how this disease affects minorities. But we can't do it if people do not volunteer. And finally, it's going to take education. You have to become educated about your own health and about your own healthy aging and what the risk factors are for this disease. You know, you can do something to prevent Alzheimer's disease right now. You can control your diabetes. You can control your high blood pressure. You can relax and be happy. You can remain active, both cognitively, physically, and socially. And you can eat a healthy diet. Those are things that you have control over. As a noted teacher and author who lived to be 100 said, life is short and it's up to you to make it sweet. I'd like to just thank my collaborators and my funding, and I'd be happy to take any questions now. Thank you.